existing prevalence of highly resistant bugs, as I say, these bugs mutate to become resistant to multiple classes. So, again, probably just speaking completely generically and not as a molecular biologist or basic scientist, that if you can develop a novel drug class, meaning the drug is bactericidal via a novel mechanism, then that would be of interest. However, depending on what that mechanism is, some antibacterial mechanisms are very easy for bugs to mutate to respond to, and others aren't. So, novel drug class that acts by a mechanism that isn't easily amenable to, adaptation by the bacteria would be a very generic answer to your question.
Okay. All right. Thank you for that. Fair enough. So, we understand over the past several years there have kind of been some new additions to the treatment landscape. And, this next round of questioning, we just really kind of want to understand what your perceptions are around these, what they are, kind of what are some of the advantages and disadvantages. So I'm going to just be more specific and just start want to ask you if you've had any experience with, or are you familiar with, first, Avicaz, Zerbaxa, Vabomere, or Zemdry?
Right. So the list you sent me before, I've used Avicaz probably a half dozen times or more, but I haven't used the other three products that was on the list there when I responded. Okay,
and why didn't you use? I'm just curious. Was that because the situation didn't call for it, or is that because they weren't on formulary?
Oh, then they're not on formulary. They're not available to us.
Okay, but are you familiar with those Zerbaxa and Vabomere and Zemdry as well?
Just by name, but not much beyond that.
Okay. Well, can you talk to me a little bit about what you think some of the advantages are of Avicaz, seeing that you've used it a little bit, and then some of the disadvantages from your experience?
Yeah. So when Avicaz came out, I guess a couple of years ago, I had a very warm spot in my heart for it because Avicaz is ceftazidime plus a beta-lactam inhibitor. And back 25 years ago when I was a resident and fellow, ceftazidime was one of the first third-generation antibiotics out there, and we used a lot of ceftazidime. So that brought back a lot of nostalgia for me. So, Avicaz is not a novel concept. It's a beta-lactam antibiotic with a beta-lactamase inhibitor attached to it. A cephalosporin with a beta-lactamase that obviously extends its spectrum. So the reason we've used Avicaz, again, I would say probably in the last 2 years, maybe a half dozen times, was I think most of the times, if not all the times, and this is just off the top of my head, was for our highly resistant Klebsiella infections, where that was one of the few antibiotics that covered the bug.
So, doctor, do you save Avicaz to your worst case scenario?
Well, we typically don't use it empirically. Again, to my recollection, most of the time we've used it was when we already had the sensitivities of a highly resistant bug, and then the Avicaz was used. Maybe a minority of the time, but I'm not remembering exactly whether we actually started Avicaz empirically. But to do that, we would have had to have some sort of historical suspicion or reason to do so. So typically Avicaz wouldn't be used as an empiric starter antibiotic.
So I'm curious about that. Just theoretically speaking, if I'm looking to buy insurance for, my family, I'm looking to buy insurance that kind of has the broadest coverage for all my members. Thinking about, let's say, that first go of empiric therapy as an insurance plan, why wouldn't you want to go with a broad spectrum antibiotic that has, activity against some of those, tough gram-negative resistant bacteria, to know that you're covered, so to speak? Because we've been hearing that kind of more and more, and I'm just curious to know why that is.
Yeah. So the reason that all of us are sitting down having this telephone conversation right now, talking about MDR bugs, is because we have completely inappropriately overused broad-spectrum